we're going to talk about the respiratory system. This will be an assessment and some other details. Here's your objectives. So looking at this, we want to review the structures and their functions, go over some terminology, look at considerations for the elderly population, look at obtaining data, early and late signs of hypoxia, diagnostics, and just a quick review of acid-base imbalances. So the primary purpose of the respiratory system is gas exchange. So we're exchanging oxygen and carbon dioxide between the atmosphere and the blood. The respiratory system is divided into two parts, upper and lower. Here's the upper respiratory tract. As we know, we take in air through either our nose and or our mouth. And you can see here the various structures. There's mucus that traps dust particles and bacteria. And then cilia will take the mucus either toward the larynx to be swallowed or to be coughed out, expectorated. We have sinuses. They are air-filled cavities that line the mucous membranes, and they basically decrease the weight of the skull. They produce mucus, as you know, and influence the quality of your voice. So air enters the respiratory tract through the nose, and then the nasal cavity connects with the pharynx. And that's basically, as you can see here, that is a tubular passageway that's subdivided into three parts. So you will know the nasopharynx, the oropharynx, and the laryngopharynx. And it also, the nose is going to give protection to the lower airway. It warms and humidifies the air. It filters out small particles before they enter the lungs. Your olfactory nerve endings are located in the roof of the nose, and that's responsible for the sense of smell. Air moves to the oropharynx, to the laryngopharynx, and then it travels to the epiglottis before moving into the trachea. The smaller picture here, you can see the vocal cords that are in the larynx. And the epiglottis is a small flap located behind the tongue that closes over the larynx during swallowing and prevents things from going down into the lungs. Vocal cords are in the larynx. Vibrational sounds are made during respiration, leading to vocalization. So that's how you talk. The one thing I want you to notice here is that the trachea bifurcates into left and right. The right side is shorter than the left side and a little straighter. So a lot of times if anything does go down into the lungs, it's more likely to go into the right side. The carina is located at the level of the manubrial sternum juncture. So if you hit that when you're suctioning, that's when coughing will occur. Here's the lower respiratory tract. So you've got the bronchi, the bronchioles, the alveolar ducts, and the alveoli. Everything is located in the lungs except for the left and right main stem bronchi. Once air passes the carina, it is in the lower respiratory tract. And like I said before, the right main stem is shorter and wider, and it is more likely that that's where your aspirate will go. Don't forget that the right lung has 3 lobes and the left lung has 2 lobes. Now, circulation. There's 2 different types. There's pulmonary and bronchial. The pulmonary circulation provides the lungs with blood, and that's the part that participates in the gas exchange. The pulmonary artery receives deoxygenated blood. It's one of the few times that you'll know that the artery gets deoxygenated blood. and that comes from the right ventricle, and then it goes into pulmonary circulation and connects with the alveoli. Then there's oxygen-carbon dioxide exchange at this point. The pulmonary veins return the oxygenated blood to the left atrium, and then it goes out to the body from the left ventricle and via the aorta. Bronchial circulation starts with the bronchial arteries, and they arise from the thoracic aorta. Bronchial circulation provides oxygen to the bronchi and other pulmonary tissues. Deoxygenated blood returns from the bronchial circulation and empties into the superior vena cava. Now, the structures of the chest wall, the ribs, the pleura, and the muscles of respiration are important for respiration, obviously. So you want to make sure that everything's working well. The chest cavity is lined with a membrane called parietal pleura. Remember that from your anatomy. And the lungs are lined with a membrane called visceral pleura. And they both join together to they form like a closed double-walled sac. So they protect the lungs. They lubricate it for movement. Here's some terms to know. Sometimes we get these two confused, SaO2 and SpO2. So your SpO2 is what you know as your pulse ox. You put it on the finger, and it's an indirect measurement of the saturation, the hemoglobin that shows up in your fingertips. So that's how we measure it. We can do it on the forehead, the ear, or the finger, sometimes the toes, although I don't think that's very reliable. The SaO2 is a measurement of the saturation of oxygen within arterial blood. So that's in your ABG, your arterial blood gas. It's a partial pressure. And then last of all is something that's coming more and more in my practice. I saw it as more favorable way to measure. It's called EtCO2 or end-tidal CO2. So the person exhales, and then a beam of infrared light is passed over the gas sample on a sensor. And the presence or lack of CO2 is inversely indicated by the amount of light that passes through the sensor. So, if the CO2 is high, you'll get a low infrared signal, and a low CO2 yields a high amount of light. So we want to know how much is coming out. So are they holding on to CO2? This is particularly useful in code situations, but also in procedures where I wanted to know, did I over-medicate them? Did we give them too much? Because if they're not blowing off enough CO2 and they're retaining, that's not good. So we're going to have to wake them up a little bit. It also helps you know in a code situation what's going on. So CO2 yields a high amount of light. CO2 levels are displayed. It's a detector that looks similar to the pulse ox, and then we adjust it for the presence of nitrous oxide. It's done by the machine. The measurement by capnograph is end-tidal CO2. So we want to look at ventilation, the movement of air from the external environment to the gas exchange units of the lung. Okay. It's spontaneous or mechanical, whether perfusion is the delivery of fluid through the blood vessels to the body tissues. And this is essential to provide oxygen to the cells. Blood has to pass through the alveolar membrane for diffusion and oxygen and CO2 to take place. Surfactant, remember that from last semester, that's a protein. That's a lipoprotein, actually. It's produced by the cells lining the alveoli, and this lowers surface tension within the alveoli. It prevents collapse of the lung by stabilizing the alveoli and decreasing capillary pressure. So that's an important term to know. Sometimes you can pull up on YouTube really good examples of how surfactant works. Here's some other terms too. pH, it's the measurement of acidity or alkalinity, and it's based on how many hydrogen ions are present. Remember that hydrogen is an acid. So if we have a lot of hydrogen ions present, it's going to have a low pH or acidic. PaO2 is the partial pressure of oxygen that's dissolved in arterial blood, and PaCO2, the amount of carbon dioxide dissolved in arterial blood. So we're looking at blood gases on both of those. I'm going to zip through this a little. You can read about this on your own, chemoreceptors, and really it's part of the body's system of feedback. The body is amazing. It's just it's so well designed. It's meant to be efficient. So if I get too low in a particular quality like PaCO2, something will happen to raise it. Like the hydrogen concentration, if we're acidotic, it causes the medulla to increase the respiratory rate, so we blow it off. More chemoreceptors, looking at this just a little bit, and just read this over on your own. Pretty interesting. I'm not going to test on it, but I think it's something that you can read about. Now, control of respiration. The central nervous system controls voluntary and involuntary respirations. A lot of times you're breathing, you're not even aware that you're breathing. Maybe if you're working out or you're nervous during a test or something like that, you recognize you're breathing faster. But for the most part, you're not even aware that it's going on. Now the respiratory system is in the pons and the medulla in the brainstem. So if anything happens to the brainstem, respiratory functioning will necessarily be affected. The diaphragm is the major muscle of respiration, and you know that. So the ventilation involves inspiration or inhalation or movement of air into the lungs, and expiration or exhalation, movement of air out of the lungs. That's pretty simple. Contraction of the diaphragm and the intercostal and scalene muscles increase the chest dimensions. Breathe yourself and you can feel it. And this will decrease intrathoracic pressures because there's more room. So gas flows from an area of higher pressure, remember that? From higher pressure to lower pressure. So from atmospheric to intrathoracic. Compliance. This is going to be important, especially when we look at COPD. This is how well our lungs are able to expand, how well they're able to distend. And it's a product of elasticity of the lungs and elastic recoil of the chest wall. So if compliance is decreased, the lungs are more difficult to inflate. So think about that with COPD. Now, oxygen and carbon dioxide move across the alveolar capillary membrane, and again, from higher concentration to lower concentration. So oxygen is moving from alveolar gas to arterial blood, and carbon dioxide from arterial blood to alveolar gas. Diffusion continues until equilibrium is reached. And remember that diffusion is the process of oxygen and carbon dioxide moving back and forth across the membrane. Here's your mechanics. Put your hands on your chest wall and feel this. So remember that the diaphragm is the major muscle of respiration. I'm going to keep saying that even though you know it. So the diaphragm contracts and thus it moves downwards. The chest muscles contract. The rib cage is pulled up and out. The lungs expand and negative pressure is created. So now air from the atmosphere flows into the lungs. The air from the atmosphere has a positive pressure. And then the muscles relax. The rib cage moves back to the original position. The lungs return to resting position. And the air is passively exhaled out. We really, unless you're doing sometimes some certain yoga or some exercises, you're really not going to blow out. This is a YouTube. You can look at this separately. Really need to concentrate on the normal respiratory rate. I've watched people, colleagues, I've watched people, nursing students, I've watched everybody. A lot of people do not count respirations. If somebody's having a problem, maybe they're asthmatic or COPD, you should count for a full 60 seconds. The other thing is you've got somebody talking, you've got somebody concentrating on their breathing. So the best thing to do, I've found in my practice, is put my stethoscope on their back, put my hand on their back, and just say, okay, just breathe normally, and then I count their respirations, and they're not even aware that I'm counting. You really want to get an accurate count. Normal respirations are between 12 and 20 breaths a minute. And it's really critical that you notice when they're breathing too fast, like say maybe 28 breaths per minute. It's very important because they're blowing off CO2. Eventually they're going to tire out and then they will stop breathing and they will hold on to the CO2, which is really bad. Here's some terms to know: excretion and secretion. Structures and functions of respiratory system. Again, we're talking about more chemoreceptors and mechanical receptors and stretch receptors. So read about this on your own, but you do want to look at this Herring-Brewer reflex, and you can see above how it controls respiration. More structure and function. So looking at the goblet cells, the mucus, and how they work, the cilia. So they're defense mechanisms. They basically keep us from taking bad stuff into our lungs. So we hope that they're working well. Keep in mind that when people smoke cigarettes or other things, that a lot of times the cilia can be destroyed. So it's very important that they have good and working defense mechanisms. Nasal hair, we talk about that, and it filters inspired air, so large particles are removed, but the smaller ones can get through, and the cough reflex brings it out. For age-related, NCLEX is definitely interested to know that you know some of the age-related effects on the respiratory system. So it has nothing to do with illness, it is expected. For elderly people, and usually we're talking over 65, so their immune system's less effective. They can get sick easier, so we see this with COVID, certainly with the flu. Flu vaccines are important for elderly to get, for everybody to get, but for them, and pneumovax. People have a decreased cough reflex. If you've done any work at all in a long-term care facility and you've done feeding or been in the dining hall, you've seen this. The cough reflex is not as effective, so they're at risk for aspiration. Kyphosis, this picture here, which shows that, and sometimes their chest appears barrel-shaped. They may need to use accessory muscles to breathe. Respiratory muscles decline after age 50. So the lungs are harder to inflate too. Actually, a lot of problems, O2 levels decrease. Really, the best thing that people can do is be active and stay healthy. Get their immunizations, stay away from sick people, drink plenty of fluid, all those things. Respiratory defense mechanisms for the elderly are indeed less effective, and there is a decline in both cell and humoral mediated immunity. The alveolar macrophages are less effective too, so again, they're more at risk for having infection. Now, when you go to assess, people just jump in there and get their stethoscopes and start moving them around. They don't even listen for inspiration and expiration. They just keep going, going, going. The first thing you should do is inspect. You should inspect and look at the front and the back of the chest. Look for color. Look for symmetry. Look for any incisions or scars. Look for abnormalities like kyphosis or scoliosis or anything that can cause a problem with respirations. Note if the person is barrel-chested. Look at how they're breathing. Do they look comfortable or are they working hard? Next thing you do after inspection is palpation. So you'll palpate with your hands. Just warm them up and warn the person that your hands may be a little cold. Feel the back. Feel for any lumps, bumps, anything abnormal. Feel for even where the bones are. You can feel for your anatomy. And in percussion, you will need this order for NCLEX and Kaplan, but you typically won't percuss, and we'll demonstrate percussion in the lab. And then last but not least is auscultation. This is the correct order for an exam. It differs from abdomen, as you notice here. Auscultation is last. So you have to know your anatomy, and this one shows some anatomy. We're going back to inspection now. So one of the other things you need to look at is fingernails. You can see here, and you remember this from way back in PN1, normal versus clubbing. Notice their positioning. Are they in a tripod position? Are they using accessory muscles? Nasal flaring, is that present? How's their capillary refill? Is it brisk? Does it take a while? What type of breathing is going on? Is there any reason why they're would not be able to breathe, like maybe a lesion in the brainstem? Look for equal chest expansion, barrel chest. Look at the rate, skin color. Remember that if they are going to be pale, people with darker skin look in the mucous membranes. This is a Kaplan and NCLEX answer. And the other two are types of breathing. Abnormal lung sounds, you can listen to this one. This is a YouTube. If you haven't ever heard crackles or wheezes or any of these, this is very effective. These are patterns, and it gives a brief description on each. So now we're looking at people and how are they positioned. Like the top gentleman, he's really probably having a hard time breathing. He can't sit down and he has to rest on something. The other person next to them, they're in a tripod, and then the third person is a modified tripod with some pillows in place. Here, percussion and auscultation should be performed in a planned sequence, so you should plan to start and go across. And just like you see here, we're going above the clavicles, if you notice here in the front, and then on down in a sequence. Listen to the left side, listen to right side, listen to right side, listen to left side. But don't just listen to one side. Even if they say I'm having trouble on the left side, listen to both and compare. It's great if you can do the axillary too, and the posterior. And when you hear something, document where did you hear it. Did you hear it in the left axilla area? Did you hear it posterior? I want you to notice by this picture that the lungs extend further down posterior than they do anterior. Here's some breath sounds, and if you use your own stethoscope and listen to your own breath sounds, and I hope that your breath sounds are normal, you can hear over each one what's supposed to be. So bronchial, over the trachea. It's a little louder. Bronchiovesicular over the main stem, and then vesicular all over the rest of the lobes. If you hear bronchial breath sounds in where you're supposed to hear vesicular, that's a problem. So Make sure you're listening over lung tissue, not over bony prominences. Listen to at least one inspiration and one expiration. And note the pitch. Are you hearing any high or low pitch sounds? Some of the terms that you're going to hear are crackles. Older nurses might still say rails. Sometimes I even say rails. So rails, it sounds like that snap, crackle, pop, and it's really fluid in the lungs. It will be in the bases first because it's heavy, so gravity will pull it down. Not heavy, but heavier than air. So it would be in the bases first, working upward. What I want to know when I hear crackles, is this normal for this person? So sometimes elderly people will sit in a chair for the whole day and their lungs aren't working as well, so the fluid accumulates in the bases, and that may be normal. But crackles 3/4 of the way up, halfway up, that's not normal. I want to listen, get some vital signs, and make sure that the RN or the physician knows. Then coarse crackles, there's a difference, and again, it's something you have to hear. Fine or high pitched, and coarse are more bubbling sounds. This is more common in pneumonia with a severe congestion, or COPD, or heart failure, or pulmonary edema. And again, something, if you're hearing it for the first time, I would grab somebody and say, what am I hearing? Wheezes and rhonchi. Rhonchi sounds like rumbling or snoring, and it's from obstruction in a larger airway. It's common in chronic bronchitis, COPD, and pneumonia. And it's more prominent on expiration, so listen carefully. When am I hearing this? The change, if I hear rhonchi, a lot of times I will say to the person, cough. Now with my stethoscope in place, of course, and then I'll go back and listen again, and if it's still there, I will document that or that it cleared with a cough. Wheezes are higher pitched, they're more squeaky or musical, and it's rapid vibrations of the bronchial walls. So I think of asthma on this. A lot of times I hear expiratory wheezes, even audible, when I'm standing next to the person. Expiratory is not as bad as inspiratory wheezes. Now that's a bigger problem. Stridor, remember that from last year? That's that crowing sound, constant pitch, and it's a partial obstruction of larynx or trachea. So a lot of times we hear that in croup or epiglottitis, vocal cord edema from intubation after they've been extubated. So I always want to know, is the baby mobile? Can they pick up things and possibly swallow them? So you want to look at those things. Remember, if it's epiglottitis, you do not want to use a tongue depressor because that will cause some more problem from that swollen airway. These are some early signs of inadequate oxygenation. Restlessness, to me, anytime my patient was restless, I wanted to know what's their pulse ox, should I get a blood gas, what's going on, let me listen to lungs, get my vital signs, listen to them talk, can they talk? This is really important. I want to look at how fast is their heart rate, are they sweating, what all is going on. These are early signs, and again that apprehension too, something bad's going to happen. These are late signs. I think it's kind of explanatory that if they're confused, you're too late. Sometimes they're combative, they're pulling at things, they never did this before. And of course, if they're in a coma, it's totally been missed. So look at all these things on here. These are late signs. Now, some of the diagnostic studies, some of the things that we love to do is obtain sputum. So we're going to look at that more on the next slide. If we can get them to cough it up, it's so much better. Just give them a container and you can walk away and let them cough it up and then clean them up and whatever else. And the specimens, we can send them for culture and sensitivity. But sometimes they can't, so the respiratory will come and do an induced sputum study. And then that last one you see there, acid-base smear, and we usually need 3 early morning specimens. A lot of times that's going to be for TB. For a sputum, and you'd love this picture. So first of all, we're going to look at PPD, purified protein derivative, or the MAN2 test. It's standard testing for TB. I know you all know it. The injection is intradermal. We use about 0.1 mLs, and this, it does not say you have TB. It only identifies activation of the body's immune system in response to TB organism. There's no distinction between active and latent disease. Sputum testing, like I said on the last slide, acid-fast bacilli, we would look at this. This is more conclusive, and ideally you get 3 sputums on 3 consecutive days. Now you would think X-ray, we've talked about X-ray confirming things, but X-ray will only show TB, that there's scarring, or it can't tell that it's new or old. So sputum is going to be your best way. We have pulmonary function tests, and we also have exercise tests that you can look at here. We do use a spirometer, and that's someone trained uses that to determine how they're doing. Of course, chest x-ray. CT, always make sure if they're going to get contrast that you've checked for allergies to iodine and shellfish. Some other things that you need to do if they have contrast, you have to ask if they're taking the medication metformin if they're diabetic, because that can cause some bad problems that interacts with the contrast. And the last thing, you also want to know their creatinine level. And I'll say that a lot during the semester. For MRI, you should have by now already looked at the radiation safety. So for MRI, no pacemakers. Now there are pacemaker compatible MRIs, but in general, this is something that, so if you got a question on this, you wouldn't say, well, is this a pacemaker compatible MRI? It will say that in the question. So make sure you know if they have a pacemaker or an implantable defibrillator. Also, if they're wearing wigs, if any metal in their body, the whole host of things. Don't forget to look at that again. VQ scans are often done, especially for pulmonary emboli, and this assesses the ventilation and perfusion of the lungs. They do use a radioisotope to assess perfusion, and for the ventilation portion, the patient inhales the radioactive gas, xenon or krypton, and this outlines the alveoli. If I've got a normal scan, it shows homogeneous radioactivity. If there's diminished or absent radioactivity, it's suggestive of a lack of perfusion. So maybe there's an emboli in there causing a lack of perfusion. Ventilation without perfusion suggests pulmonary emboli. Pulmonary angiogram, similar to a cardiac cath, going in through typically the femoral artery. I don't know that they use radial, but I will check. And they will, again, this is contrast is used to light up or to show the pulmonary vasculature. And then PET scans. So this is we're looking for malignancy, so to speak. So again, PET scans, it can distinguish between benign and malignant pulmonary nodules. Bronchoscopy, the main thing I want you to know here is that they are MPO, they are sedated, when they wake up, you have to make sure that the gag reflex comes back before they can eat or drink. So it takes about an hour So we're documenting that and watching them carefully. Sometimes they do go back to the room, but make sure they're MPO until that gag reflex comes back. And bronch is just, it's diagnostic. Specimens can be obtained through this procedure. Lung biopsy, this can be done transbronchial through that last that we saw, or it can be done by a needle aspiration, or we can use video assisted thoracic surgery. VATS, VATS is what you're going to see. And then there's also an open lung biopsy. What we want to do is obtain tissue or cells and evaluate it for malignancy. Percutaneous needle aspiration, so we put a needle through the chest, and usually we're using CT guidance. There's always a risk of pneumothorax, so for this you want to make sure that you listen to lungs before and got all their vital signs, including pulse ox, and then after, and then of course assess always for any difficulty breathing. And you can read about these here. Transbronchial biopsy, and this again bronchoscope, and we're going in to take a specimen from that tumor or lymph node. And sometimes on these we will be doing these to transplant patients. Thoracentesis, for this one I want you to note the positioning. They're sitting up. I've done many thoracentesis. I can't ever remember sedating anyone. So rarely do we get sedation, mainly because it has to do with their ability to breathe. So if they can't breathe, I've sedated them, that's going to cause a problem. So thoracentesis, we do this in order to get a little specimen, or sometimes just to take fluid off, or both. You've got your person sitting up. If it's a bedside table, I'm really cautious that I've blocked off the wheels so that they don't move and jerk forward and fall. Before it starts, of course, I'm listening to lungs, getting vital signs. It's done by a physician or a provider, and they are cleaning off that area. They're going to anesthetize with lidocaine or something similar. Sometimes we do put in chest tubes, so I keep one nearby just in case they need it. And then afterwards they're going to have a chest x-ray. I'm also going to tell them to breathe deeply, and that will help reinflate any lungs if there's a problem. Pulse ox is absolutely necessary. I want to make sure that they're not getting hypoxic. ABGs, this you can read over on your own, including mixed venous blood gases. So that's drawn from a pulmonary artery catheter, and we look at the venous blood. And the rest of these I'm going to zip through because these are all acid-base imbalances, and you can review these on your own. The regular PowerPoint will also be posted. And there's the references. Thank you.